So we're going to take it from that the student has got the scenario as part of their OSCE, and for this particular scenario we're going to take it that we're dealing with an unresponsive patient. So when they walk into the room, they'll have their gloves on them, they'll be worried about scene safety, universal precautions, minimum of gloves, number of casualties 1, mechanism of injury. They're not really sure, or they might have been told in their scenario, and do we need assistance? Well, they'll find out after the primary survey. So the first thing they would look for, if it was trauma in particular, they'd ask the instructor, is there any catastrophic bleeding? And if there is catastrophic bleeding, they would deal with it either through bandages. If that doesn't control it, they would use hemostatic dressings. If that didn't help, they would then move on to a combat tourniquet, like so. And what they do with the combat tourniquet, they put it about 2 inches above the wound, and they'd mark the time and mark it on their PCR. So we take it that there's no catastrophic bleeding or it has been dealt with at this stage. The next thing they're going to be worried about is C-spine. So they would ask their number 2, unfortunately I don't have a number 2 with me at the moment, so they would ask their number 2 to take up C-spine from behind and keep the in-line manual stabilisation, like so. Be careful not to move the head. So from there they're going to go on to their airway, breathing, circulation, disability, expose and examine, and they're going to make their clinical status decision from there. So when we're talking about the airway, they kneel down beside. The first thing they do is see can they wake the patient, I suppose would be the first thing. Hello, can you hear me? And we'll say for this there's no response. And they're going to look in the mouth and to see is there anything in the mouth, any obstructions in the mouth. If there is, they can take them out, or if it's blood or vomit, they can measure from the corner of the ear to the corner of the mouth, keep an eye on the tip of the tongue and suction on the tongue and suction on the way out in a circular motion for no more than 15 seconds. Once they have the airways clear, they can take an OPA, and what they can do is then they can measure from the corner of the mouth to the corner of the ear, select the right one, insert it, and then invert it, like so. And now we can take it that the airway is secured. So now we're going to move on to our breathing, what we do in breathing. And bearing in mind, all this is done in less than 1 minute, but we're just taking things nice and slow for today because it's the first time we've done it. So we're going to go down, we're going to have a look at the breathing rate. We're going to look, listen and feel. So for no more than 10 seconds, I'm placing my hand on his chest, and I'm trying to get an approximate rate and rhythm. And once it's compatible with life, I'm happy enough. If it's less than 10 or greater than 30 and the patient is unresponsive, I would ask my colleague to use a bag valve mask and to help ventilate the patient. So along with breathing and that, we're also going to get an SpO2 monitor. We're going to put the SpO2 monitor on the patient. I'm going to keep an eye on that. The SpO2 should be between 94 and 98%, and if it's not, then we would ask, if the patient's not being ventilated, we would use some type of non-rebreather mask. We're also then just going to do a quick auscultation. 4 points at the start: midclavicular, midclavicular, mid-axillary, and mid-axillary. Just seeing that we're getting good air entry. Going to move on then, that's breathing sorted. We're going to move on to circulation. So with circulation, because the patient is unresponsive, we're going to check the carotid pulse. I'm going to check it this side, so excuse me, and I'm also going to check the radial pulse, which is this side, because I don't want to be leaning over the patient. And again, I'm going to check it for no more than 5 to 10 seconds. And all I'm looking to do there is to make sure that the patient has a pulse and that it's within normal range. It's not too fast, it's not too slow, it's regular and it's not irregular. I also get his thumb and just press down, hold it for 5 seconds and then release it, and hopefully it'll come back. I'm checking cap refill, I'll come back 2 seconds. I'm also checking the patient's skin colour and temperature just to make sure that it's in line and it looks how it should be. And that's all we do in the primary survey for circulation. Then moving on to disability, what we're doing then is, the first thing we're going to do is get a little pen light like so. We're going to check the patient's pupils. So if the eyes are closed, we're going to open the eyes and we're going to shine the light into their eyes and see are they reacting and what size. This gives us a few clues to what may be going on. If the pupil gauge is 9 millimeters, the pupils could be blown. If they're pinpointed too, it could be blown, could be a head injury. Pinpoint pupils could be maybe an opiate overdose or something like that. So the next thing we're going to do is we're going to do an AVPU assessment. So AVPU just means A is the patient's alert to person, place and time. Voice is that they are a little bit confused. They're awake but they're a little bit confused. And then P is if you were to put a bit of pain stimuli on the back of their hand, they might pull it away. Or if they don't pull it away when you put a bit of pain stimuli, they could be unresponsive, or they are unresponsive, okay? So the next thing we're going to do is we're going to go on to our E, which is our expose and examine. So we're going to start at the top of the head. We're just going to have a look in the ears. We're going to check for any blood or CSF. We're going to look in the nose. We're going to make sure that airway is still secure. We're going to check at the back of the neck for any step in and step out. Make sure that everything feels okay. We're going to have a look at the trachea. Make sure that it's nice and central. It's not over to one side. We're going to check the clavicles for any breaks or anything like that. And then we're going to check the sternum. Just make sure the sternum is intact. We're going to check the rib cage. Excuse me. And we're going to take our hands out, looking for any blood or anything like that, or any feel anything. Then we're going to go down to the stomach. We're going to check the 4 quadrants of the stomach. And we're just going to make sure that it's nice and soft and tender and not hard and rigid. It should be nice and soft and tender the way it should be. If it's rigid, it could be a sign of internal bleeding maybe or something like that. So the next thing we're going to do is check the pelvis nice and gently with the back of the hands. We're going to checking for any crepitus or instability. We're also going to check for priapism to make sure that there's no spinal injury. And we're also going to just check down as far as the knees and just check that there's no fractures in the femurs. So from there, I'm ready to make my clinical status decision. So the clinical status decision can be one of 3 things. It can be life-threatening, it can be serious, non-life threat, or it can be non-serious or life threat. So because this patient is unresponsive, I'm going to call it life-threatening, and then I'm also going to request ALS.